Doesn't have to.
You don't have to. You could easily.
Does it usually do that?
Well, with KEF it does, but not with others. They try to let us out early. So.
But I also had a lab with KEF once where we were done everything and she made us sit there for 15 minutes. So I think that's just her.
Kuhn did a guest lecture and he wound it up a little bit early, and that's it. That's all we've had so far.
Oh no!
No. We had STARP.
But I think she. No.
We didn't do a lab with her, but she had activities, so she broke it up with lecture
Kuhn.
activities.
I think Kuhn just did a lecture and then he.
Yeah, because his was after the test.
Oh, that's right.
Yeah, so his was just a lecture. Yeah.
Yeah, that was fun. Take a test and then sit.
Yeah.
Wait for your lecture.
Yeah, it was awesome.
He's a good speaker though, so it wasn't bad.
All right, so how's everyone doing? You too. Good to see you all. So I mean, there's sort of a lecture component and a lab component to this course, ideally, right? So I will be lecturing the course for a little while. I did want to include sort of a lab component as well, however, and certainly we don't want to be, I could, have infected half of you and have the other half of you do patient assessment of those others who were infected, but we don't want to do that, obviously. So how does a little practical microbiology sound after we do the lecture?
Sure.
Everyone okay with that? So I was trying to figure out a good way to do that, and I was thinking that we could do it down here. However, this really isn't a place where you're supposed to do that kind of work, and we could get into serious trouble if we did so. So I'm not sure how this will work exactly, but I have my lab upstairs all set up to kind of run everyone through, and you'll learn an example of MIC testing. So I would just ask for your patience because we're going to have the 100 or so of you all kind of hanging out in the Hannaford practice lab and then kind of circulating through the lab next door to that. So we'll see how it goes. Sound like a plan?
Yep.
Okay. So first, though, some objectives. So you should be able to identify signs and symptoms that would be useful when diagnosing and monitoring infected patients, so monitoring during and after therapy. You should be able to describe some laboratory tests and other diagnostic tests that may be used to evaluate patients who are infected or may be infected. We'll talk a little bit about culture and susceptibility testing, both today and also a little bit on Wednesday. And again, you'll have the chance to do a practical example of doing MIC testing, and you'll be able to look at your results on Wednesday if all goes well. And then we'll talk about how do you interpret those panels of MIC results, and how do you interpret susceptibility testing results when you're caring for patients and you're designing regimens, essentially. So first, physical assessment, and then we'll go through sort of laboratory and other diagnostics. And so a sample case here. So you have a patient, you're a pharmacist in the ER, and you have a 43-year-old female who comes in with her husband. She's sort of out of it, and it's more her husband who's doing the reporting of what's going on with this person. And so he describes that this patient, HK, has had productive cough, shortness of breath for the past 3 days, and then this morning she woke up, had a little bit of episode of confusion, had an episode of syncope, and so finally HK's husband thought, all right, it's time to go to the ER and see what's going on with this person. So the question is, at this particular point, without any further information, what kinds of things are you going to be doing? And I think an important point is that, infections can be emergent situations. They often are not, but there are many infections where if this person like this presents to the ER, the first thing to do really would be to do a quick physical assessment to find out, does this person basically need immediate care, or can I take a little bit more time and do sort of a careful history, etc. And so in someone like this, especially confusion, she had an episode of syncope earlier in the day, she's had a few days worth of symptoms, someone to be concerned about certainly. And again, some infections do require emergent therapy. As you've heard from me, there are many infections where you can certainly delay antibiotics and it's not going to have much of an impact on the patient's course of therapy or their clinical outcome. But there are examples. So meningitis, for example, is a very famous example of an infection that can be an acute illness, and where if you delay antibiotic therapy by even an hour or so, you can have a much poorer outcome in a patient with meningitis. So the point, I guess, basically is that you can have medical emergencies in infected patients, certainly. And agitation or anxiety in a patient is often a cause of a more systemic critical illness. So this person doesn't really have anxiety per se, but some mental status confusion would be a red flag and something to be a little bit more concerned about, the possibility of having to do an immediate intervention, basically. So then, if you've made it through that emergent phase, you start taking a history, what is important there? And so one point certainly that's important to know is that when it comes to infected patients, many of the symptoms and signs that they will exhibit are very nonspecific and might point to an infectious disease, but may point to something else. And certainly, even if you're confident of someone having an infectious disease, symptoms alone are not going to often be enough to help you rule in one infection versus another, and certainly not an organism to that level. So symptoms won't typically help you to know what you're facing as far as what you need to treat someone for. So definitely, for that reason, detailed history is important to not only establish the diagnosis, but often in infectious diseases, the history is one way that you can pick out something that would put someone at risk for a certain etiologic agent, certainly. Another important thing would be the onset and the duration of symptoms. So this person, HK, has had symptoms for 3 days. So that might lead you to some conclusions about what disease process might be going on. There are certainly infections that can kind of come up out of nowhere, and so you could wake up tomorrow and suddenly you have meningitis, and you know, one day to the next you have a really sharp decline in your symptoms. But you can have other infections that are a more gradual, sort of indolent course that suddenly the person might crash as a result of those symptoms. And so onset, duration are important, as well as severity of symptoms and any changes in severity of symptoms. So if this person, HK, had maybe a week's worth of so-called sniffles, but then suddenly she started developing more productive cough, started producing sputum, then that leads us to believe that she's having basically a progression of whatever is going on in her. So going through aspects of the history and things to ask patients about or ascertain from patients. And so the first big one, as far as what to ask patients about, would be host factors and comorbidities. And so comorbidities can play a role in the disease state someone may have. It can also play a role in the causative agents. And so there are certain comorbidities that put patients at risk for different causative agents. So these are just some of the examples of things you want to look out for or detect in patients. And so patients who lack a spleen, or so that are asplenic, are at risk not only for certain diseases, they're also at risk for certain pathogens. And so, for instance, Streptococcus pneumoniae is an important cause of infection in patients who lack splenic function. Hepatic disease certainly is a big concern that can lead to some certain types of infection, again, some certain etiologies as well. Hepatic disease also becomes important down the road when you're giving patients therapy, because there are certain antibiotics where you have to be careful about patients who have hepatic disease. HIV infection, common cause of immunosuppression, and sometimes profound immunosuppression, especially in patients who maybe are in the later stages of their HIV infection, have full-blown clinical AIDS, and have really, essentially a non-operable immune system, basically. IVDA, IV drug abuse, major source of infection as far as a way for pathogens to gain entry into the body. IVDA, for instance, is a risk factor for endocarditis, for instance, and so patients who are chronic IV drug abusers are often at risk for endocarditis as a direct result of their IVDA. So that's an example of a lifestyle situation that would put someone at risk for certain infections. And then the last three are really examples of other types of immunosuppression. And so certain types of malignancy, organ transplantation, also patients who are receiving chemotherapy for malignancy, all have the potential to cause sometimes extremely profound immunosuppression, which puts people at risk for, again, certain infections, and then also certain etiologic agents that may not affect maybe you or me. So for instance, with HIV patients, they often, especially when they're in the later stages of their disease, have infections caused by rare pathogens that you wouldn't see in your average normal healthy person, but that can cause opportunistic infections in those patients. including pathogens that are in the environment to which we all get exposed to one degree or another, but we have good immune systems, and so we basically don't really care about being exposed to those pathogens. But HIV-positive patients, for instance, and other immunosuppressed patients can acquire infections caused by those sort of environmental pathogens. Next would be sources of invasive infections. So getting at what might be the source of someone who presents with symptoms like HK. And so did someone have a recent upper respiratory tract infection? And so even something as relatively benign as otitis media, infection of the ear, fairly easily treatable infection, no one dies from otitis media basically, but having had otitis media can predispose to other infections, can predispose to things like meningitis, and so that would be an important part of the history is getting at, does this person have, for instance, a recent case of otitis, and might that put them at risk for having more serious infections as a consequence of that? Another thing, too, would be if someone has had a recent episode of otitis, for instance, they've probably received antibiotics for that infection, and so you start thinking about antibiotic resistance playing a role maybe in the current infection. Things like trauma as well, other disruptions of our skin definitely does a very good job of protecting us from pathogens, and often disruptions in the skin can be a way that we get infections, unfortunately. So doing a good history as far as did the person have any recent burns, any recent surgery, other things like has the person just come back from getting a tattoo, did they just recently have a piercing, and so piercings can definitely lead to infections, not routinely, but another disruption of the sort of cutaneous barrier, so foreign bodies as well, so piercings, etc., can sometimes put people at risk for infections. I think a big thing when it comes to infectious diseases, which makes infectious diseases somewhat unique, is the importance of exposures, and so travel, for instance. And so there are certainly parts of the country and parts of the world where if you've been recently to one of those areas, you are suddenly at risk for a disease that we may not think of if you're someone who's been in Maine for the past 2 months, basically. And so definitely looking for travel to especially exotic locations, and so some examples being West Africa and Ebola. Soviet Union has huge problems right now with extensively resistant tuberculosis, so if someone just came back from there, you might put that a little bit higher in the differential than you otherwise would. Contact with animals, including pets as well, so pets can actually carry some infections, and so, for instance, one question I often ask of people is, so raise your hand if you have a dog. Keep it raised. Or you've had a dog in your lifetime, basically. So keep your hand raised if you allow your dog to kiss you on the mouth.
I do. I admit it.
So maybe disgusting, and I'm keeping my hand raised because I'll admit to that. So, you're probably not going to get infected from that. It might be a little bit disgusting, but for instance, dogs are known to be, in certain cases, carriers of MRSA, for instance. And so if you are petting your dog and hanging out with your dog, you could potentially acquire MRSA. Now, is it a high possibility? No, and you shouldn't go home and start avoiding contact with your dogs. But the point is that pets can be actually a source of infection, especially, again, if you're someone who's immunocompromised. Does anyone have a pet turtle by chance, or had a pet turtle? So you might be at risk for salmonella infection, actually, having a pet turtle. Pet birds, anyone? So birds carry all kinds of things, potentially. And so, again, don't change your behaviors, don't get rid of your pets, but especially, again, if you're someone who has a profound immunosuppression, you can sometimes have exposures with your pets even that can lead to infections. On a related note, if you've been camping recently, is there a risk that you had a tick exposure or a mosquito exposure? So, we don't have malaria in Maine, really, but if you went to a malaria endemic region and had a mosquito bite, suddenly malaria becomes a concern, whereas it wouldn't, again, if you were in Maine for the last couple of months. From a tick point of view, Maine, unfortunately, is a fairly heavy region when it comes to Lyme disease, and so that's always a concern if someone has had a tick exposure. There are other diseases that are associated with tick exposures as well, in addition to Lyme disease. Occupational exposures, so there are certain occupational exposures that would put someone at risk for infections. Dietary intake, and so, are there any fans of raw oysters in the room? A few. So you can acquire certain infections from eating raw oysters. Again, primarily if you are someone who has immunosuppression, you shouldn't stop eating oysters, in my opinion. Certainly food poisoning can be a factor if you've had some recent intake of something kind of questionable. And then social contacts as well. So some big ones there would be exposure to daycare facilities, for instance. And so in daycare facilities with children unfortunately harbor lots of infections. They're more commonly infected than adults for the most part. They also, depending on their history, might be patients who have received lots of different courses of antibiotics, putting them at risk for acquiring resistant pathogens. And so, if you happen to work in a daycare facility and you're part-time and you're not in the college of pharmacy, for instance, you might be at risk for acquiring infections that you wouldn't necessarily be aware of. Other social contacts would be certainly looking at a sexual history, and so there are many infections certainly that can be acquired through sexual means as well. So really looking at any kind of risky social contacts would be important. Medication history, really two primary reasons to look at medication history. One would be when you're designing therapy later on, looking at drug-drug interactions. But I think in this early diagnosis point of view, more importantly would be, is the patient receiving any drugs that would make them immunosuppressed? And so the classic one would be corticosteroids. And so again, not a short course of prednisone would not make you immunosuppressed, but if you were on long-term, especially high-dose steroids, then that could make you basically functionally immunosuppressed. Again, changing maybe the list of diagnoses and the list of pathogens. Allergies, of course, are always important, more so when designing a regimen, and finally, vaccination history is always important too, because if someone is fully up to date on their vaccinations, then maybe there's certain pathogens that we'll be less concerned about, and also certain diseases. But if someone is, for instance, it's been in the news a lot recently with the vaccination denialists and people who refuse to vaccinate their children, that then leads to a different potential pool of diseases and etiologic agents if someone isn't up to date on their vaccines. So any questions on the history? So just briefly with review of symptoms, I know you've learned about just the general strategies for doing a review of symptoms, correct? I think ID is important because really a couple of the big ones when it comes to ID as far as review of symptoms would be those top two, so neurologic and dermatologic. Neurologic in part because neurologic manifestations often are real specific indicators of certain diseases, and so meningitis, for instance, patients with meningitis have very unique neurologic symptoms that really would be a red flag to make meningitis more of a concern in your head. Neurologic also, again, because someone who presents and they're febrile and they're confused or they're anxious, that then also would indicate, again, that need for perhaps a little bit more urgent care of someone like that. Dermatologic because, again, many infections have an origin through some disruption of the cutaneous barriers, and so someone might have a rash that then leads to a bacteremia, and the person becomes septic, and they basically have a much more serious illness. And so often skin manifestations precede other types of infections. From a respiratory point of view, certainly many infections can have a respiratory source, and especially this time of the year, we have lots of people with respiratory illnesses, which can be self-limiting, or they can lead to more systemic illnesses. Gastrointestinal is also another route of infection, as is genitourinary. So often, for instance, urinary tract infections might precede more serious infections. And so really, when it comes to infectious diseases, if things get into your bloodstream and you become bacteremic, that's when things really go downhill fast. And so, a UTI might be a very easily treatable infection, but if a UTI becomes pyelonephritis, so advances up to your kidneys, that becomes more serious. Then if you have seeding, so-called seeding of your blood, so the organism gets into your bloodstream, then you have a much more serious condition. And so review of symptoms becomes important really as a way to see, are there any predisposing infectious conditions that may have led to the current condition. Physical exam, I know also you've learned sort of some of the typical strategies of physical exam. To point out a few infectious diseases specific physical exam issues, so general appearance certainly is important. Patients really can run the gamut from lethargic to agitated to seriously to ill. Remember again that fever, while it's the so-called cardinal sign of infection, is absent in many patients. So elderly patients, for instance, patients who are taking NSAIDs, who are taking aspirin, etc., can often fail to show a fever. From a vital sign point of view, the three important ones really would be BP, heart rate, respiratory rate, to see if someone does have hemodynamic compromise. So again, your septic patient who has bacteria in the bloodstream, when they become septic, they have things like cardiovascular collapse, low blood pressure, hypotension, often which is an emergency situation which requires things like hemodynamic support, fluids, etc. Respiratory tract assessment is important, again, because many infections have some element of respiratory involvement. You want to make sure that someone's airway is not going to be obstructed due to an infection like pneumonia, for instance, which often can cause a true obstruction of the airway. From a skin and soft tissue point of view, in addition to looking at that as a sort of a nidus of infection or a source of infection, other important things would be looking for rashes and lesions, and there are some dermatologic manifestations of non-dermatologic diseases. And so, for instance, on the bottom, those two pictures are, on the left, what's called Osler's nodes, so OSLER, and on the right, a Janeway lesion. And so those are dermatologic manifestations of endocarditis. And so those are hallmark signs of someone who has endocarditis, and you have these dermatologic manifestations that are actually a part of the diagnostic workup of someone with endocarditis. And so there are other examples as well. For instance, syphilis has a very characteristic rash on the palms of the hands, for instance. So other things that can help you when it comes to a diagnosis. Looking for things like erythema, edema, tenderness would be important to rule out things like necrotizing fasciitis. And so when you have deep-seated muscular infections, which can be also extremely serious, life-threatening infections. From a neurologic point of view, again, as I said, things like meningitis have very specific neurologic symptoms and signs, so you want to make sure you rule out things like encephalopathy, meningitis. There are also focal neurologic findings which can indicate as well certain infections. And so, for instance, photophobia, for instance, would be one of the hallmark signs of meningitis. And so someone basically woke up in the morning, opened their blinds, and just the light coming in through the window basically was painful to that person. That would be an example of a very focal neurologic finding that does not make you able to diagnose meningitis, but it's a very cardinal sign of meningitis. So any questions so far? So let's revisit the case. So this person has had HIV infection for 17 years, hypertension for 6 years. From a social history point of view, they say that they smoke 1 pack per day, they have occasional alcohol use. Medications include lisinopril and AAA. Anyone know what AAA is used for? Right, so HIV infection. So that's one of the combination products that can be used by itself to treat HIV. So we don't really know the status of this person's HIV infection. They could be, HIV is nowadays a very manageable chronic condition, and many patients with HIV have perfectly functioning immune systems, but maybe this person hasn't been adherent with their AAA, or maybe they're having the emergence of HIV that is resistant to her therapy, which is a fairly common thing that happens, unfortunately. So really the HIV thing here would be a red flag of something to follow up on that, again, could put this person at risk for different diseases and pathogens beyond a normal, healthy person. The hypertension, really, I would say we don't really so much care about that. It doesn't really put someone at risk for much of anything when it comes to a particular infection. So physical exam shown here. So I'll let you look through that for a minute or so. So what things jump out at you? So green sputum, I heard. So yeah, we shouldn't be having sputum production, and if you are, it shouldn't be green. And actually, colors of sputum can sometimes point to a certain pathogen. It's not really a definitive thing, but for instance, green sputum can give you maybe a sense of what bacterium might be causing someone's pneumonia. So analyzing colors of sputum is actually a diagnostic tool as well, believe it or not. So what else? So she has a fever, right? So she's above that 38.5 cutoff.
Lung sounds.
Lung sounds, so definitely not normal as well. What about the respiratory rate and the heart rate?
Low and high.
Quite high, right? Blood pressure?
Low.
Low, right? So hypotension. What else? One more, I think. That's right, yep. Right lower lobe dullness to auscultation, which indicates something might be in there. And then what else? One last one, I think.
Appearance.
Not oriented to time.
Right, so this person's A&O times 2, so they are oriented only to place and person and not to time. And so, again, some indication of maybe there's some confusion and something more serious going on, basically. From a laboratory testing point of view then, so what do we look at? So electrolytes certainly are important. CBC with differential is extremely important, so looking at things like an elevated white count, looking at an increase in the proportion of bands, which again are those immature neutrophils. So having more bands basically means that your bone marrow is producing white cells trying to fight off an infection. Liver function tests also important, especially when it comes to if you decide to use a drug that you have to worry about liver function tests as far as hepatic dysfunction as well. So from a lab testing point of view, fairly routine. Diagnostic materials becomes important. And so in this person, HK, we probably want to get sputum samples, right? We probably want to get blood cultures. We often get blood cultures in patients who we don't necessarily know have a bloodstream infection, but unfortunately, pneumonia, for instance, often goes hand in hand with a bacteremia at the same time. Again, this person is showing some confusion, more acutely ill, which makes you think even more so that they may have a bacteremia and not just pneumonia. God bless you. So we're definitely going to take blood cultures. Blood smears are a specific type of test that's used to diagnose certain infections. So for instance, malaria is diagnosed by doing a blood smear and looking under a microscope and seeing the organisms. Anyone with meningitis, you're going to want to get cerebral spinal fluid to analyze that as well. So on the right there, you see an illustration of a lumbar puncture, sort of LP, where you're going in with a rather large needle through the vertebrae, and you're basically going into to grab cerebral spinal fluid, basically. So fairly non-invasive therapy, despite the fact that that illustration may look sort of scary, but you know, something that you would routinely do in someone in whom you suspect meningitis in order to get a sample of CNS to see what's growing in the CNS fluid. Sputum we mentioned, urine samples in patients who you suspect maybe have a UTI or pyelonephritis. And so really, if you suspect an infection somewhere, you probably want to try to get tissue from that or samples from that site of infection if you can. And then finally, imaging. And so, for instance, with pneumonia, according to the current practice guidelines, you have to do a chest x-ray to diagnose pneumonia. If you don't do a chest x-ray, you can never conclusively diagnose pneumonia. So in HK, we certainly would be scheduling a chest x-ray to see if we can see what's going on in her lungs. If you have people who are showing neurologic signs, you might want to do MRIs of the head, CTs of the head. We can do CTs and MRIs of lots of different areas. So if we suspect that this person maybe has an intra-abdominal infection, we might do an abdominal CT or MRI to see if we can see what's going on. And then urinalysis would be another example of just a kind of a random test that you would sometimes do, again, because UTIs kind of often precede or go along with other more serious infections. So getting back to the case then, so here are her labs, and you've learned this method of showing lab results, correct? So what jumps out at you here?
High glucose.
You're missing glucose a little bit, right? What do you think of the white count? So extremely low, right? So kind of the opposite of what you might expect. So this person doesn't have a leukocytosis, they have an extremely low white count. Have you learned about ANCs?
Mm-hmm.
So an ANC is an absolute neutrophil count, and it basically tells you the percentage of white cells that are neutrophils. And so an ANC of 375 is a low count as well. And so basically this person is what we would say is having febrile neutropenia. So she has a low white count and is febrile at the same time, which is a really serious condition. So she not only is fighting off an infection, but she lacks as much ability to fight off an infection as if she had a normal white count, and she's also febrile. So febrile neutropenia is a condition in and of itself that can be a fairly serious condition. So from a radiographic imaging, we correctly did a chest x-ray in HK, and we see right lower lobe consolidation consistent with pneumonia. And then from a microbiology point of view, we have both sputum and blood cultures that are pending. So I just wanted to show an example of how do you use these different physical findings in order to, when it comes to infectious diseases, decide on treatment therapies. And so in the setting of pneumonia, which HK we think probably has, there actually are defined scoring systems that basically physicians and other clinicians use to decide how they want to approach that patient. And so so-called CURB 65 scoring is one of the more used ways of doing this. And so this basically allows you to try to systematically assess what is the risk of mortality in this person, and given that risk of mortality, how do I want to treat this person? And so as you see there, you basically just give a point. So if HK is confused, which she has been, right? If her BUN is over 7, which it is, if her respiratory rate is over 30, which it is, if her blood pressure is low there, as you see, she was in that age as well, or in that range rather, and if you're older than 65. So really with HK, the only one of these that she doesn't have is that age over 65. So she gets basically 4 points on her CURB 65 score. Then as you see there in the middle there, if her CURB 65 score was 0 or 1, then we think her risk of mortality is fairly low from this pneumonia, and we can just treat her as an outpatient, basically. If it was 2, she's sort of in the middle ground there, and we would probably hospitalize her and treat her as an inpatient. Maybe not for the entire course of therapy. We might discharge her for home therapy after a few days of antibiotics. Unfortunately, HK, though, with her score of 4, she's going to be admitted not only to the hospital, but basically directly to the ICU, because she is at risk for high level, or she's at a high risk for mortality due to her pneumonia. And that's just the pneumonia. We think she might have bacteremia as well, perhaps, depending on the blood culture results. So she's even in graver condition, unfortunately, if that's true. So any questions on that? So any questions at all on kind of the approach or the history of examining or kind of diagnosing patients with infections? So getting to the laboratory diagnosis. So continuing on with the case. So HK is diagnosed with pneumonia based on the chest x-ray results, largely, other signs as well. She also is classified as having febrile neutropenia. So again, her ANC would be indicative of neutropenia, and she's febrile, certainly. So she gets admitted directly to the ICU. So she's in this empiric phase of therapy where we kind of have an idea of what she has. We don't know if she has bacteremia as well, but we know she has pneumonia. We have no culture results yet, so we're just choosing empiric therapy. So when you're choosing empiric therapy, you're often going to be using fairly broad spectrum regimens. So we start her on piperacillin tazobactam, ciprofloxacin, and then we throw on some antifungal coverage as well with fluconazole. You could maybe even argue to give her antiviral coverage, but we gave her just 2 antibiotics and 1 antifungal. So we're still waiting for our culture results, and this is that empiric phase of therapy where we're essentially just guessing that we are covering her pathogens. So then on day 2, you get blood and sputum cultures. They're positive. You have gram-negative bacilli, and that's all you know at first. So you've done a gram stain, and you see those gram-negative bacilli, which perhaps narrows or not perhaps, it should narrow what you're considering as causative agents in this person. Later in the day, the organism is finally confirmed from a species point of view to be Klebsiella pneumonia. However, you don't know what drugs are active against this isolate, so your testing as far as susceptibility is still pending. You correctly discontinue fluconazole because you have no evidence that this person has has a fungal infection. So you do the right thing as far as trying to de-escalate your therapy, but you keep this person on piperacillin tazobactam and ciprofloxacin. So You're certainly providing broad gram-positive, gram-negative, and anaerobic coverage. So you're covering most bacteria that would be thought to be a causative agent in HK basically right now, whether she has pneumonia only or whether she also has bacteremia. So you're covering things like Pseudomonas, you're covering anaerobes, you're covering staph and strep reasonably well. So you're providing a pretty good empiric regimen, so you think probably you're in the clear maybe. Then you go to day 3, however, you finally get back your results when it comes to the susceptibility of this isolate, and it's revealed to be susceptible to tigacycline and colistin only. And so, as you've seen in the news recently, there have been some outbreaks of what's known as CRE, or carbapenem-resistant enterobacteriaceae. This would be the profile of one of those CRE isolates. So, resistant to everything except colistin and tigacycline. So, agents that you wouldn't typically use in an empiric therapy. So basically, this person for 3 days or 2+ days has been receiving placebo antibiotics, essentially. We've not been doing anything to cover her pathogen. So then, predictably later on day 3, despite you changing her regimen to provide coverage of this Klebsiella pneumoniae isolate, the patient expires, basically. So the point, I think, of this sad story, I suppose, is that when we're diagnosing infection, the hallmark way that we diagnose infection from a microbiologic point of view is we take cultures, we grow those cultures, we wait until there's positive growth, then we speciate the organism, then we do MIC testing to guide what therapy we can use. The typical duration or time course of doing that would be, as is shown here, so 3 days until you really have all of your information. And so, culture dates back essentially centuries, and so yet we still in the modern day of medicine use these somewhat antiquated methods to diagnose infection. And so we'll talk a little bit about maybe some alternatives to this antiquated way of doing things. So this is a table showing kind of the evolution of different types of diagnostic methods and the associated time that is required to identify a pathogen in someone like HK. And so microscopy certainly is fairly short, and so earlier today, for instance, in my lab, I did a gram stain. It took me probably a half hour, and so you can fairly quickly identify whether someone has gram negatives or gram positives, et cetera, growing in their body. However, many pathogens won't grow. Many pathogens are hard to culture, so that becomes a limitation. As you see, gram stain there again, fairly short turnaround. Culture and other associated methods are fairly long turnaround, so a couple of days at the very least. Things like Mycobacterium tuberculosis takes weeks sometimes to grow in culture, and so someone could be receiving therapy for tuberculosis, and you don't know yet what drugs are active against that strain of tuberculosis. As you see, doing MIC testing, days to weeks as well, depending on the pathogen. So the point is that really there's unfortunately a risk to have ineffective therapy while you're waiting for these results that take sometimes days to weeks. And so we'll just touch on today, but we'll talk more on Wednesday about some alternative methods. And more these days we are entering the phase of doing rapid diagnostics. And so serologic diagnosis, antigen testing to identify certain pathogens. Now more and more we do more sophisticated analyses using things like PCR and sequencing and next generation sequencing. And so those all really are designed primarily to offer a quicker turnaround time, and so avoiding the situation that we had with HK where she was receiving inadequate therapy for 2+ days basically and died as a result. So we'll talk about a few of these different methods more so on Wednesday though. So this shows some of those different methodologies, and so again we'll go into details on these on Wednesday, but again more and more these days we are entering the phase of these rapid diagnostics. The unfortunate thing with rapid diagnostics is that, as you would expect, they are expensive compared to culture and other associated methods. They also are not as available, especially in resource-poor environments. And so, for instance, in some parts of Africa where we have huge concerns with HIV and meningitis outbreaks, you're not going to be able to do PCRs basically out in the middle of some of these African countries that are resource-poor, et cetera. So I think we're moving to using a lot of these, but unfortunately there are still barriers to using these types of more rapid diagnostics. And then have you learned about sensitivity and specificity and the difference between those when it comes to tests? Or no? A little bit maybe. So I think just especially for next week, it's important to know the difference between what makes a test sensitive versus what makes a test specific. And so one of the ways that I learned how to differentiate these would be spin versus snout. And so snout basically tells you that a sensitive test, when it's negative, helps to rule out the disease. And so basically, if a test is 100% sensitive, and then it should identify that disease state in all the patients that are tested with that test. So a sensitive test would help to rule out a disease if it is negative. And then a specific test helps to rule in the disease when the result is positive. And so, for instance, VDRL testing is a hallmark way that we diagnose syphilis. There aren't many other conditions where you would have a positive VDRL, and so it's a specific test for syphilis, basically. So if it's positive, it would rule you in for having syphilis. So one other limitation to some of these more rapid diagnostic tests would be that some of them have either low sensitivity or low specificity, which complicates or makes them less useful than they would be otherwise. So is that fairly clear? So again, some of these novel techniques, which we'll talk about next on Wednesday, so we'll talk about some more unique culture media that might allow you to have more rapid diagnostic testing just by growth on different types of culture media. We'll talk about antigen detection, serology. We'll talk about some nucleic acid-based testing, some PCR-based methodologies, and we'll also talk about some newer proteomic-based testing on Wednesday. So shifting gears a little bit before we go upstairs. So how do we measure antibiotic sensitivity, which technically should be susceptibility? And so the technically correct term that microbiologists use would be susceptible, not sensitive. What I learned as a student was that people are sensitive, bugs are not sensitive, basically. So that said, there are even microbiologists that will refer to something being sensitive, so it's not the end of the world if you use that term, but the preferred term would be susceptible. So when we're doing this type of testing, what are we basically trying to figure out? So we're basically measuring growth of an organism in the presence of antibiotic concentrations in vitro, so in a laboratory-based setting. And we're trying to use those results to predict clinical success in vivo in our patients. There are a variety of methods, which I'll show you in a second. There's both qualitative methods, which basically tell you the organism is resistant or not, and there's quantitative methods that tell you the actual numerical value of the concentration that inhibited growth of that organism. In the US, there's an organization called CLSI, which basically makes the rules and writes the instruction manual on how we should do MIC testing in our patients. So some examples. Some of you, has anyone ever seen diffusion testing perhaps? So this is one that you may have done in your microbiology laboratory-based days, basically. So here we have an agar plate, basically. So we chose an agar that would allow growth of this organism. We spread the organism across the agar plate. We then put down paper discs, that each disc of which was impregnated with a certain antibiotic. And so what you do is you then inhibit, or rather you incubate the plates for about 24 hours, and you see growth, but then you also see zones of inhibition around each one of those discs. And so the disc diffuses out from the drug, rather, diffuses out from the disc, and you have a zone of inhibition. And so a larger zone of inhibition is better, certainly, and so what you then do is you measure the diameter of these zones of inhibition. You go to the CLSI documents, and they will tell you, based on the zone of inhibition, the organism is either resistant to or susceptible to that antibiotic. It doesn't tell you the value of the MIC, it just tells you basically sort of yes or no, you can use that drug. So this is the only one of the qualitative methods for that reason. Next would be microdilution. I have a few examples upstairs for you to look at of microdilution. And so these basically are 96-well tissue culture plates. You have a variety of different concentrations, and so each column in this plate has a different concentration. When we're doing MIC testing, we almost always work within this very defined range of concentration. So we start maybe with 1 milligram per liter, and then 2 milligrams per liter, and then 4 milligrams per liter. We don't typically test things like 3.5 or 3.1. It's 1, 2, 4, et cetera, as you see here. So you set up a plate like this so that you have these different ranges of concentrations. You add your organism, again, you incubate overnight, and you look for cloudiness, which indicates growth. And so in this example, MC is a medium control to make sure that your medium is sterile, which it is, thankfully. Then if you look at the column that has 0.125 milligrams per liter and 0.25 milligrams per liter, you have growth in those wells. And so the lowest concentration that inhibits visible growth is your MIC, and that in this case is 0.5 milligrams per liter. And then finally, e-testing, and so the e-test is the newest method of doing MIC testing, and so e-tests are these proprietary strips. So each one of these plastic strips basically has one antibiotic kind of coating the strip. So you would also take your agar plate, you would coat it with your bacterium, you would lay your strip down basically, again, incubate overnight, and then you would, after that incubation period, you would see, again, sort of like just diffusion, you have diffusion of the antibiotic into the agar and you have inhibition of growth. The way these strips work is that you have your highest concentration on the very top and it goes down gradually, and so you have a larger zone of inhibition at the top of the strip where you have your highest concentration. So the E-test stands for ellipsometer testing, and so you have this ellipse because you have gradually declining concentrations. And so when you read these, you simply look at where did the growth line basically cross the strip and what number corresponds to where that happened, and that's how you read your MIC. And then finally, certainly in hospital settings, much of this is automated. There actually is no automated way of doing e-testing, and so if someone in a microbiology lab does e-testing, which sometimes happens, that's done very much as you will do in a few minutes here, basically. But when it comes to most routine MIC testing, you have a variety of different commercially available automated systems for doing so. This is just one example of one of the more common automated systems where they have these panels. Within those panels, you have different wells with different drugs that will tell you whether the drug is resistant to that drug or not. So I think I guess I sort of explained this a little bit, but this is an example of the microdilution methodology, basically. And so, again, you have this range of concentrations that you've set up. You have your differing concentrations. You add your organism, and you look for the lowest concentration that inhibits growth. So this is sort of a graphical representation of this photo. And so in this scenario, we tested ciprofloxacin, we tested E. coli. Our MIC is 2. So the question for you is, if this was HK, for instance, and she had pneumonia caused by E. coli, which wouldn't be very common, but it can happen, and we wanted to use Cipro, and our MIC was 2, could you use Cipro or not? So you have, your choices are yes, no, or I don't know, I need more information. So how many would vote yes? A couple. How many would vote no? How many would vote I need more information? So I think just the fact that that's a choice probably is a giveaway. So you need more information before you can make that decision. And so on Wednesday, we'll talk about how do you interpret these MICs and how do you then use that data to help you decide whether to use Cipro or not in this person, for instance. So any questions? All right, so again, hopefully this works. Bear with me a little bit. This is a first to have 100 or so students up through the lab, basically. So just a couple of things about what we're about to do. I think it's, we are going to be working with pathogenic bacteria. They're not terribly risky bacteria, and they're bacteria that I work with all the time. They're bacteria that I've had many students work with. Knock on wood, nothing has ever happened as far as people becoming exposed to things, but you do want to be careful. So you're going to all be wearing gloves. You're going to all gown up with those disposable gowns that you've probably used before, right?
Yep.
And then you're going to definitely want to wash your hands after on your way out, basically. So we want to be careful. But again, these are all pathogens that pose a relatively low risk of infection. Is anyone concerned about the prospect of working with these things? And if you're truly concerned and want to opt out, you certainly can. But again, these are all pathogens that I've worked with quite often.